Good morning, one and all. Today we are discussing a case of recurrent jaundice in a 3-year-old child. This is a 3-year-old male child presented to us in October 2012 with complaints of recurrent jaundice, recurrent episodes of jaundice since 1.5 years of age. Each episode was associated with high-colored urine and occasionally pale-colored stool also. Each episode was treated outside in some hospital. The treatment details in written was not available when the child was presented to us. In between these episodes of jaundice, child recovers completely. And he is coming to us in October 2012 with the 4th episode of jaundice.
Each episode, I think, was also treated at some form of a native medicine, some native medicine center, not allopathic doctor, each medicine.
Family history, this is a second-born child to second-degree consanguineous parents. Elder sibling is well. There is no family history of jaundice or any liver disease. Antenatally, mother had a fever in first trimester, but there was no rash or no jaundice. Probably said to be enteric fever outside, no records available. This is a term IUGR baby. Birth weight was low, 1.75 kilogram. No history of birth asphyxia, no history of neonatal jaundice. During infancy and until the 3 years of age, by the time he is coming to us, he was having the issues of failure to thrive, developmental delay, mainly motor, and a recurrent wheezing episode, which was treated outside with nebulization and occasionally oral steroids. Documented weight, which we found, 6 months he had a weight of 4.1 kilogram, birth weight is 1.75, and at 3 years, 2 months of age, when he is coming to us, weight was 8 kilogram, that is below 3rd centile. We also had some of the investigation available with us in November 2011, that is around 2 years of age. 1 year before he comes to us, he was investigated outside by a hematologist, very well known in Chennai. The exact symptoms mother is not remembering right now, but looking at the investigation, it looks that he was investigated probably for pallor, hepatosplenomegaly, and failure to thrive. These are the investigation which was done outside in November 2011, hemoglobin 10.1, ESR 45, peripheral smear, some dimorphic anemia, reticles around 2%, G6PD normal, DCT negative, electrophoresis normal, iron is low, and there is no jaundice. Serum bilirubin 0.3, liver enzymes, okay. And CMV, IgM was done, probably because child was low birth weight, failing to thrive, having a hepatosplenomegaly, and it was said to be weekly positive outside.
Wait, Rashish, why did they do it every week?
Pardon, sir?
You said weekly positive. Oh, we. Okay.
This is the during the current episode of jaundice. That is the 4th episode.
Go back. Spelling mistake. It's okay. WEAK.
Oh.
So obviously this was not done during an episode.
No, this is the outside investigation.
Yeah, but even outside done during
this
an
was
episode.
not done during one of the episodes of jaundice.
Somewhere in between it was.
Somewhere in between. All the episodes of jaundice have been treated by some native medicine clinic.
And there is not a single investigation during previous episode.
Not available.
This is all that we have. We are as puzzled as you.
So what all is there? Let's see this.
This is the only thing that is there before he came to us.
What is it? Pruritus is it?
Pardon, ma'am?
Pruritus was present?
No.
No. There was no history of pruritus.
No, it's still problem.
Hemolysis, that's what I want to know.
That we will come, ma'am. This is the outside investigation which the parents given to us at the time of presenting to us. These were done around 1 year back by the child coming
How
to us.
severe was this developmental delay?
Yes, I will come.
Maybe coming.
Oh, you're still coming
Yes,
to a lot of things. Huh?
Very difficult, long history.
Yeah.
During this current episode, child is deeply icteric, having minimal ascites, hepatosplenomegaly is there. There was no history of pruritus, irritability, seizures, encephalopathy, or no bleeding manifestation. No past blood transfusion, no hepatotoxic drug child was on. There is no family history of jaundice or any liver disease.
The only thing is, as far as the hepatotoxic drug that we want to mention, I think we don't have the details of what native medicine therapy the child underwent during each episode of jaundice.
You're not looking at it as a cause of the jaundice rather than.
It may be.
This is all the information we have, sir.
Your smile tells me something. As a drug.
On examination, child is having severe pallor, deeply icteric, mild pili dilemma is there. Looks malnourished, weight is 8 kilogram, less than third centile. Height is 75 centimeter, almost equal to 1 year height, less than third centile. Head circumference 46.5. For this 3 years of age, it is less than third centile. But if we see the height 75 centimeter, the height age is almost 1 year. For that height age, head circumference is almost 50th centile.
This is like a dysplastica UGR.
Abdominal examination from hepatomegaly, histolomegaly 3 centimeter, minimum free fluid is there. CVS and respiratory system normal. CNS wise, there is no focal neurological deficit, no involuntary movements. Developmentally, child had some motor delay at 3 years of age, is able to walk few steps only without support. After that, he falls on the ground. He's quite malnourished. Otherwise, he is able to feed by cup, not by spoon. He speaks only few words, maybe 3 or 4 word sentences. He identified fruits and colors. He is very interactive with parents and doctors also, and indicates the bowel blood habits. So the developmental was delayed is more of gross motor. Sir. So this is
There's a global delay, but it's more in motor.
More in motor.
I think but there's a global delay. I think.
So to summarizing, antenatally mother is having fever in first trimester, birth weight is low, 1.75 kilogram, child is having developmental delay, mainly in motor, along with failure to thrive, hepatosplenomegaly and recurrent episodes of jaundice. Outside told to have CMV infection, current episode again deep jaundice and minimal ascites.
Click one more.
What do you think?
Panelists.
Neonatal period was absolutely uneventful.
Why don't you give it to the audience first before we take it?
Yes, the audience. What do you think? Anybody from the audience?
Differential diagnosis, that was
We can have wide and nice, big, wide differential diagnosis. I am as blank as all of you are, so it's okay.
Pale stools also every time.
Yeah, mother tells he had pale stool in between sometimes. But it recovers spontaneously. In between the episode, child is well.
We basically want a differential diagnosis in a 3-year-old with recurrent episodes of jaundice.
Since 1.5 years of age.
I mean, if you're looking at 3 years with recurrent episodes, it's much easier. But 3 years with recurrent episode with developmental delay makes it a little more complicated.
Absolutely, sir.
Can you tell us something more about that?
He's malnourished also.
Hepatosplenomegaly, I mean, how big is the liver and
Go back
spleen?
to
Is it
go back to the slides.
3 centimeter firm consistency, sir. Sharp margins, spleen 3 centimeter, minimal ascites is there.
Okay, so let me just take it from here. If you want recurrent jaundice presenting with thing, and with child is giving a high colored urine, I don't think we have the lab here, but previously so it doesn't look like it's a primary hemolytic disease. It's definitely with all this picture looks like a liver disease.
Yeah, outside hemoglobin was 10 point and something.
Yeah, but the high colored urine is what you have said the previous episodes. Every time was high colored urine. So that means it's pointing to the liver. Now liver disease, conjugated jaundice, quite possibly episodes with a hepatosplenomegaly is a liver disease. So which liver disease presents recurrently is what I'm looking at. So to my mind, one of it would be autoimmune hepatitis. I'm just doing generally. Second is whether it is some sort of a recurrent intrahepatic cholestasis, but there is no pruritus and you won't expect hepatosplenomegaly in that situation. That's the second part. And whether there is some sort of a biliary problem, a choledochal cyst or something which is happening there, something which is coming, which is causing localized infections, cholestasis opening up again. I mean, these are the 3 things primarily that just come to my mind at this particular stage. And if you are very sure that there was no drugs before the previous episodes, because we know that there are some drugs which are given annually or something which are given on a regular basis, every time the patient can have reaction to that and develop jaundice. And albendazole, and there are enough reports to say that every time he was given albendazole, there was hepatitis. So those sort of things are the ones that come recurrently, at least based on. But none of them I can explain the developmental delay at present.
We had the very same confusion when we dealt with this child. And among the 3 things that you mentioned, one is autoimmune, one is biliary, possible choledochal cyst, and possible drug-induced, etc. We also considered the same. But of course, we didn't consider possibility of autoimmune very high. It's a male child, it's 1.5-year-old. Recurrent cholestatic disorders is something that was very high on the cards. We couldn't explain any of the developmental delay in microcephaly. So we sometimes thought, was he unfortunate to have 2 separate conditions, or is it part of the same condition? Go on.
I think the one LFT that we have is essentially normal.
Essentially not.
So that means it's something that's occurring episodically. And
Episodic.
between the liver is near normal.
Near normal.
Yeah, normal.
Just a point, huh?
But finally, I mean, now that there is a 3 centimeter spleen and liver which is firm, whatever happened in the past, but it's gone on to lead to something now, and the liver is definitely affected.
Yeah, the liver is definitely affected. Yes, with you.
You can't ignore 68 value of SGOT and SGPT.
It's near normal.
No, it's
actually.
not near normal. 40 is normal and this is almost 1.5 times the normal. So you can't ignore that.
Yeah, there's something going on. Okay.
Just one sentence that you made was that this is a male child and younger age. We know that it happens in younger age group also, AIH, and in the younger age group, the genetic predisposition is not there. So it can be there in both.
Yeah, as what sir
The
said.
gender predisposition, sorry.
1.5 year. 1.5 year.
First episode was 1.5.
1.5 year of age.
Yeah, as what sir said, like we cannot ignore that LFTs which are not near normal. Second thing, maternal history is not significant, but a IUGR baby with a low birth weight who is having these recurrent episodes, there is failure to thrive. We might consider even a TORCH group of infection which could have been there, and most of the TORCH, the mother may not come with a history, it is just like a viral illness during pregnancy. And if it is an intermittent neonatal, I mean if it is a neonatal hepatitis with intermittent episodes of cholestasis, the jaundice can keep on coming.
Why?
Congenital
That is what is the
infections
confusion.
having recurrent episodes, I don't think is
Yeah.
Any,
on the board.
any congenital
It may explain
infection.
So we are
development
very
of
happy for
recurrent
that.
episode of jaundice.
No, I understand that part. We are very happy for the TORCH group of
Yeah.
infections to cause failure to thrive, IUGR, all of that. That part is okay. We are happy for it to cause a little bit of hepatosplenomegaly. We are not happy for it to be asymptomatic until 1.5 years and suddenly cause jaundice for 3 times.
What I meant to say was that in between the SGPT is coming down to near normal. That time the child is no jaundice. So probably during the episodes there is cholestasis and secondary hepatitis, but in between it's coming to near normal. That's what I mean. You could think of some paroxysomal disorders also which could have recurrent jaundice.
Metabolic conditions
Metabolic.
like mitochondrial paroxysmal is
The other
also
one is
on the
again a
cards.
storage disorder, Niemann-Pick type, one of the types. I don't know that they can come with recurrent.
Peroxisomal mitochondrial was definitely something that we
Paroxysomal is a
thought
strong
about.
possibility that.
Okay, well, let us give some
You mentioned
investigations.
about wheezing. How significant was the wheezing episodes? Was it like with every episode? or
They've
just-
had a few nebulizations. Go on.
So these are the investigations that we did at our hospital. At first presentation, October 2012, hemoglobin 6.1, total count 10,000. Platelets are so far normal, 1.7 lakh. Peripheral smear, actually they evaluated by 2 hematologists. Both are suggesting there is dimorphic anemia with evidence of hemolysis. Cystocytes, spherocytes are there and WBC are showing lot of toxic granules. And both hematologists strongly suspecting some intrauterine infection, probably CMV.
They also saw the child clinically. That's the reason why they're suspecting this.
Reti count is 4.5%, serum bilirubin 24.5, direct is 13.2, more than 50%. SGOT 2490, SGPT 760, SAP 1660. Albumin is fairly low, fairly normal, 3.3. Prothrombin time is prolonged, 32 seconds against the control of 14. INR is 1.85 and serum bile acid is 65.
The biochemical, okay, now if you were to split it up, the biochemical picture may fit into recurrent intrahepatic cholestasis. Okay? High
cholestatic.
SAP, low GGT, no pruritus clinically, and occasionally you can have a high SGPT, SGT, though they are not usually so raised, but you can occasionally have, cannot explain, so whether we're looking at two different things right now, frankly.
Some of the cholestatic disorders also have failure to thrive, don't they? I mean, we've seen a lot of Alagili syndrome who have episodes of pruritus and cholestasis,
But pruritus was never there.
but this child did not have.
Did not have.
Did not
In
have.
those conditions, the liver never gets back to complete normalcy. It's always
No, the
up and
liver
down.
never gets back to complete
Yeah,
normal,
your-
but sometimes
your
they
LFT
lose
in
the
between seems to
jaundice.
suggest that it's almost near normal. There's always a baseline abnormality with periodic exacerbations and remissions. Here, it's not going to fit into that unless, like he says, these are two different things. The child's got a developmental delay and recurrent intrahepatic cholestasis. That's a strong possibility.
No, but, and also the hemolytic
There's also a hemolysis.
Hemolysis now.
There is certainly a
There is an
hemolysis.
hemolysis, and I would want to know the DCT of this child.
DCT done was negative.
Yeah, it will come. It is just a baseline investigation. This is first investigation we had, ma'am. Then we did next USG abdomen. There is showing mild
Go
hepatitis.
back to that. Globulin is 2.2. And this peripheral smear, why did they write CMV on the peripheral smear?
No, like I said, the hematologists have seen the child clinically. They've seen the peripheral smear commented, and then their opinion is it could be maybe related to some form
So
of.
they have seen the child and made the
Yes,
diagnosis,
yes, yes.
not the peripheral smear.
Not the peripheral smear. That's the reason why I said that time. So maybe you missed it. Sorry.
And the fundus examination sometime was normal.
It's coming.
Oh, it's still to come up. Okay.
Ultrasound abdomen showing mild hepatomegaly, homogeneous ecotexture. There is no evidence of biliary ductal dilation. Mild splenomegaly, homogeneous ecotexture, minimal free fluid. There is no evidence of thrombus in portal vein.
These were the doubts we had: intrauterine infection, metabolic, peroxisomal. We even thought of some cholestatic disorder like histiocytosis or some prolonged cholestatic disorder. Go on.
So it means you are no better than us at that
No,
stage.
no, absolutely not. How can we be better than you?
So we were thinking what may have caused this episode of jaundice.
Go back just one slide. We were thinking at this point of time, because he's having recurrent episodes, is it one chronic liver disease? But because he's come with very high enzymes, whether there's an acute insult on an underlying chronic liver disease, which is possible hepatosplenomegaly. So we thought we will send some acute markers and some investigations for chronic liver disease.
So these are the acute viral markers done at admission. IgM for hepatitis A negative, hepatitis E negative, HBsAg negative.
He had no history of blood transfusion, therefore we didn't do hepatitis C.
And CMV PCR in the blood and urine, because outside it was weakly positive, and the child also had low birth weight, failure to thrive, hepatosplenomegaly. So we sent CMV PCR, which is coming.
Instructed by hematologist, madam. Instructed by the hematologist, therefore. Hematologist.
Hematologist. Okay. Now, do we have any message on that? Because that's more important.
We will have a message. We have some investigations which are being done. See, this is 2012. At that point of time, we even thought, we don't know how to treat CMV, whether CMV causes, etc. There are a lot of confusions about intrauterine infections and how to diagnose CMV. So what I understand is, like if you have an IgM CMV positive, very young, if you suspect an intrauterine infection, that is not enough to treat CMV. At that point of time, our infectious diseases people suggested that ideally you need to document if it's an active infection, you need to do PCR. 2012.
In the liver?
No.
In the tissue?
In the blood and urine.
At that point of time, the thought was blood. A lot has changed in the way that we treat CMV.
Yeah, but PCR quantitative, I think, not qualitative.
True.
This is qualitative positive.
I'm just saying if you're talking of
You need to
PCR.
tell us about the fundus. I think before the hematologist did any more damage.
Yes, sir. Fundus examination is showing bilateral disc pallor.
Go on. There is no. Go on.
Metabolic workup, serum alpha beta-protein normal, lactate and ammonia, we done for mitochondrial encephalopathies, this was normal.
We followed Dr. Ashish's instruction that whenever you suspect metabolic liver disease, he always says, look for an evidence of fatty liver. So we didn't find any fatty liver. And true enough, some of these mitochondrial and peroxisomal, we've also seen only these fatty livers, so we didn't find any.
But the biliary tree was normal.
Yes,
Biliary tree was normal.
Somebody had seen it.
absolutely normal.
And the ophthalmic, sir.
Ophthalmic evaluation, no chorioretinitis.
Basically that I would still worry about, one of the things for the message is look at choledochal cyst, it's often missed. Just because an ultrasoundologist said no fatty liver doesn't mean there's no choledochal cyst.
But fortunately, sir, we are having a very good pediatric sonologist. If he says no, we are confident.
Go on.
Ophthalmic evaluation, there is no chorioretinitis, no cherry red spot, mild bilateral optic disc pallor is there. HIV ELISA negative. This is the workup because hemoglobin was low, 6.5. We thought some of the hemolysis may be going on. Reticulocyte count 4.5%, peripheral smear showing dimorphic anemia with evidence of hemolysis. Osmotic fragility, shift to left, query hemolysis. G6PD level of normal, electrophoresis normal, DCT negative, ANA negative. Further, we ask a neurologist opinion for the part of developmental delay. EEG done was normal because the neurologist has noticed some abnormal movements in the child, which we didn't find initially. MRI brain was done showing multiple tiny chronic hemorrhagic foci in the right temporal, parietal and bilateral frontal occipital regions with mild cerebral atrophy. 2D echo done, minimum pericardial fluid was there. And
It's okay. No, go on to the next fine.
this is the
So he had a mild developmental
He had
delay,
developmental
neurologist's
delay,
opinion.
some
They also
abnormal
didn't know there's no focal neurological deficit.
The neurologist must have told them to do it, isn't it?
No, but you would be surprised in all these funny pictures.
no.
You do a MRI, you pick up some pictures.
Yeah, you
that
do
point
pick up. I
towards
don't think it's
something.
not
You get
indicated that
signals,
way.
So I
Yeah.
think that's quite fine.
This is the sequential LFTs we have done during the 1 week of hospital stay. Hemoglobin 6.9 further fall down to 4.9. We have transfused the PRBC there. And serum bilirubin initially 24.5 with direct of 13.2. Next on done after 3 days 24.9. And further after 3 days 18.7. Direct has fallen to 9.5. SGOT is gradually decreasing, initially 1100 and then become 500. SGPT also decreased to 116. SAP.
Ashish, don't read out all the investigations. They're all there for people to see.
INR is still high, not corrected by vitamin K.
Okay. Now what are your thoughts, sir?
Back to previous.
Go back to
Essentially, I think there's no chronic liver disease. There is something intermittent which is resolving within a month, and the hemoglobin is dropping quite significantly during the phase of the illness. From what? It's come down to 5.1. So I think there's some hemolysis which is happening episodically.
Sir, but like you pointed out, this child is also having a chronic abnormal liver enzymes going on.
Yeah,
Significant
but it's come down quite
conjugated
drastically. Your
bilirubin
initial was
also.
2,900 and within 2
INR has always been little bit high. Why you want to exclude a chronic liver disease? I mean, the albumin is the only thing which is a little bit borderline
normal.
normal.
It's gone on for so long, for 3 years.
Is there any blood loss in stools or anywhere else?
No.
Have you done the IgG?
No, I think, Srinath, what needs to be highlighted is that alkaline phosphatase is quite high, but the GGT is normal. I mean, is it telling us that this is some liver disorder which can do that, or are we saying it's all coming from the bone? Have we looked at the bone in some way?
I think during that episode, the alkaline phosphatase went up, and then subsequently the alkaline phosphatase is also coming down, 529. So it's not like persistently. This child never had significant pruritus. We did a bile acid level. The bile acid level did come up as little bit high, 65, which is not very high. The child was not symptomatic for pruritus. So we were clueless.
Did you do a lipid profile or something like that?
We didn't do a lipid profile, sir.
And the platelet
We did
count
it.
is
Sorry, we did the triglyceride because at one point of time that's the reason why that echo was done. We suspected possible Alagili syndrome, so we did a triglyceride cholesterol that was normal.
And the platelet count is also 1.7 always. Which one?
No, you mentioned allergens, it's a persistently normal GGT. Anyway, but that's fine.
That was initially, I think.
No, you'd only think of PFIC.
Sorry.
I think that's the one thing. PFIC is one thing that you would think of, and you get this variation between ALP and GGT.
Okay. So we'll tell you what we did.
Or BRIC. BRIC is also a little unlikely. I think more PFIC type.
Okay, this one question. Is CMB a culprit? Should we do anything about it? This is a question for you to answer, sir.
CMB the culprit?
A message to pass. Is CMB a culprit? Should we do anything about it?
Obviously you want us to say no.
Look, somebody was suggesting that you need to do PCR in the blood, in the liver. Therefore, Dr. Seema, do you think CMB is a culprit? Should we do anything about it?
I do not think that this time, at 1.5 years,
The first jaundice happened at 1.5 years, and that too recurrently. Do not think CMV has anything to do with this, and I would I wouldn't even have done the CMV PCR like what you did here.
Go on.
The next question we thought.
Go on. That is answered.
What did
Go
the
on.
radiologist give his impression on the MRI? Did he give a diagnosis or did he just describe it and leave it there?
He is
Just
just.
left it there. Final, there was no impressions around this.
So there is no. What he said was tiny hemorrhagic foci is all that he described. The MRI.
But they're old ones. Or
They're old ones. Something that happened earlier on. Go on, Ashish. What we did. Go on.
And can CMV go on and on for so
Go on,
long?
go on.
with
Next
recurrent
one.
jaundice, and what may be the cause for hemolysis? So what next to do?
Go on.
What we did, we treated the child only with supportive measures, given a PRBC for anemia, and we sent a quantitative PCR for CMV. And
Autoimmune was among the cards, so therefore we sent autoimmune markers as well. Then
liver biopsy we did under FFP cover, and we discharged the child on vitamin supplements and well-gained cyclovir for 2 weeks as per the hematologist advice.
go on.
This is the follow-up LFT. Child is coming after 2 weeks, and liver enzymes are still high, and quantitative PCR for CMV has come negative. And this is the liver biopsy report in follow-up. Child has active lobular and interface hepatitis, indeterminate type, diffuse hepatocyte swelling with hepatocanalicular and dactylar cholestasis, and perisinusoidal, perivenular and bridging fibrosis with focal incomplete nodularity suggestive of evolving cirrhotic changes in the liver. Now what can be the possibility?
Go on, just go on. So this, no, this is, sorry, go on to the next step, just show.
These things, what did you pathologist say was the most prominent finding?
Yes, the
What was the
pathologist.
most prominent finding according to your pathologist?
Pathologist felt, ma'am.
No, the pathologist certainly said that there was an element of interface hepatitis and there was an element of an evolving cirrhosis. But what he said is with this, if you, autoimmune is one of the possibilities. But it's not like with this, I can tell you that this is autoimmune hepatitis.
No, I'm not saying that, but I'm just saying that then autoimmune could have come first. If this is not the order, then it's okay.
Yeah, this is not the order. Go on. This is not the order.
There should be some plasma cell infiltrate in the autoimmune, which was not there in this case. But he strongly feels it is not CMV.
Yeah, go on. So these are distorted portal tracts with a lot of fibrous expansion. Go on, next. And there is certainly piecemeal necrosis and ballooning degeneration. The big cells here are ballooning degeneration. Go on. And this perivenular fibrosis is usually also compatible with autoimmune hepatitis. Go on. And this, the reticulin stains, you can clearly see that there is some creeping fibrosis and this child is going in for an evolving cirrhosis. Go. So our questions at this point of time is we've never seen children at 1.5 years coming with autoimmune liver disease. So we didn't know whether this was autoimmune liver disease just because a pathologist suggested it. So this is how we think that there can be autoimmune liver disease. If you document an inflammatory liver histology, increased IgG, and then no other known etiology and the response to immunosuppressive therapy. Go on.
So we send autoimmune workup further, ANA titer, ASMA and anti-LCAM antibodies, all of them are negative. We did a protein electrophoresis, there was elevated fraction of gamma globulin, not very high but elevated. And immunoglobulin profiles was done, IgG level are almost double the normal value. 2508, the normal range is 600 to 1380. Almost double.
Okay, so 25, is this
Yes.
how we get it? I'm forgetting the unit there.
It's milligram per deciliter only.
Now, go on to the next one, next slide. So this is a simplified diagnostic criteria. Go on, Ashish.
This is the simplified diagnostic criteria 2008 given by International Autoimmune Hepatitis Group. The previous criteria given in 1999, which was very cumbersome to use. This is the short form of that. We have to see for antibodies, immunoglobulins level, histology and absence of viral hepatitis marker. We give a point each of them and we calculate the total score. If the score is 7 or more than 7, we call it as autoimmune. If the score is 6,
what was our score?
Probable autoimmune. So if we see our score, all autoantibodies are negative. The remaining score we have given is 5. So it's still not fitting in criteria of autoimmune hepatitis.
Okay. Now go on, next one.
Now
what to do? Yes. This is the question now.
Yeah, this simplified criteria has been given for that purpose only, ma'am, because previous criteria are difficult to use in adults.
Just go back to your previous slide. Yeah, essentially you have an elevated IgG and an IgE as well, 910.
IgE, the child had recurrent wheezing. I don't know if having some allergic tendency also.
At the end of the day, what we don't know is, what we thought at this point of time was, this child is having an ongoing liver disease, there is some evidence of some inflammation, there is some evidence of some hemolysis. Then the same questions as to what are the conditions, one of the things is autoimmune, etc. We've not been able to get any markers, serological markers for autoimmune.
You got all these, did you repeat the LFT again? Did it come back?
I think we showed those things.
The last was still elevated. A week later, did it normalize or did it never?
It started to come down. No, bilirubin started to come down, but the hepatitis is not coming down. The still SGOT-PT is still going on.
Srinivas, one important point here that your globulins were in fact low, but your IgG is high. So I think that's an important thing to emphasize. Yeah.
Globulin was 2.2.
2.2.
Globulin was only 2.2. The IgG levels were high. Go on, Ashish. So what we did, we bite the bullet, we start on steroids, okay? So go on, yeah.
So we started on steroids 2 mg per kg per day, and this is the fall of LFT. After 2 weeks of steroid, SGOT 52, SGPT 38, bilirubin comes to 1.4, and the direct is only 0.6. This
One
is
more
again
click.
we did after 1 month, OTPT is normal.
One more click.
Your
Stay
GDP
there.
has gone up to 200.
Even before it went up to 154.
Again it came to 17, sir.
Which one?
GGT went up to 200, in follow-up again coming down.
No, even
Overall,
when it was 150.
I don't know, at this point of time I was also confused. See, basically we started on steroid, we're grossly looking at the LFT. But at the end of the day, what I'm thinking is, did he have the natural clearance of the disease that he had, that he's always had since the last 3 times, or did he actually respond to my therapy, steroid?
Or did you get steroid at a native clinic each time?
We don't know.
Maybe.
That is also another point. So we don't know what.
So now the
this is a
question
question.
was, if this episode
What?
is recovering spontaneously or the child is responded to steroids.
I think yes.
So-
So what gave us the answer? So what gave us the answer is the mother stopped the steroid, June 2013.
So this was the LFT, the last we said, and after that this mother stopped steroid by themselves in June 2013 and coming to us in July 2013 with this LFT. Again liver enzymes some 3400 and 1400.
Go on.
And again we think is there again an acute episode of hepatitis which is superimposed on chronic. Again we did a IgM hepatitis A which was negative, ANA again negative.
Go on.
What do you think? We again restarted on steroid 2 mg per kg per day and this is the response. We started here on the first slides, 9th of July, and this is the subsequent LFTs. Liver enzymes are essentially normal. Child is still on steroids, 5 mg per day.
Go on, issues, go on. So I
the
think
issue-
here there is a lot of confusion. We still don't know what he exactly had. We know that this history and clinical picture right from start was confusing. At the end, I don't know if you'll agree, we thought that maybe he had some form of a neonatal insult, an intrauterine insult, and that's the reason why maybe he had his failure to thrive and developmental issues. I don't think that was related to the autoimmune. CMB is often sometimes given too much respect than what it actually deserves. And I think there should be a message that you don't go after CMB, don't go after CMB. Seldom causes chronic liver disease. We had problems because this was an unusual age of presentation as well as sex, that 1.5-year-old male for an autoimmune hepatitis. Yes, this has certainly taught us a seronegative autoimmune hepatitis can exist. There were some cost constraints, so the second time he came back after stopping steroid, we didn't repeat his autoimmune markers, so I'm not sure if having repeated autoimmune markers and follow-up could have again given us a clue, sometimes to say better that this could have been only an autoimmune hepatitis. I would like the expert comments from you, sir, before we end up.
Did the IgE come back to normal? Was the serum IgE...
We are not repeated, sir, right now. We are not repeated.
No, he has responded to steroids, but that doesn't really give us a diagnosis. It only tells you that either IgE response or IgG response is getting suppressed.
Should we repeat the immunoglobulins and autoimmune markers, sir?
Yeah.
I don't know, what's your last LFT is normal?
It's normal
last
now.
one is normal. This is
And he's on
last
steroids.
one.
The antibodies are known to fluctuate. So when you repeated the NA, it would have been better to repeat the entire panel.
There were a lot of cost constraints.
So
Family
then
comes from a very poor
don't do
family.
any one of them. There's no point choosing ANA over either of the
ANA
two.
is very cheap.
ANA is the only one that is done in our own hospitals,
Okay.
very
Very
cheap.
cheap.
The other things you need
Second
to
thing
send
is
out.
that once you have seen a response in the OTPT, I think if you had repeated the IgG, that also should start showing a response and that will perhaps increase your confidence that you're on the right.
We'll do that.
Yeah,
And
but
one
can
more
I,
thing
can,
is
can I ask the people here, I mean, is this what you would all have done? At least this is what I would have done.
I think I would have also given
Yeah,
steroids to the patient
absolutely.
and seen the response. But I would have done one more thing. For all autoimmune, where you suspect autoimmune, you must do an MRCP, especially if you have such a high, alkaline phosphatase.
And that liver biopsy also suggests...
Kamaji, do you-
The liver biopsy also is suggestive of a bridging necrosis.
One small comment I want to make. See, absolutely, this treatment plan has been very good. Only one point is that autoantibodies in children you should get at 1:20 positive. You should ask for titers. Many a times in our own institution they will give you 1:80 And when you ask 1:40 or 1:20, now we have established we should do it at 1:20. So that could be one possibility. But I think it's a fantastic case and the treatment plan has been absolutely correct. Ultimately, what are we looking at? The welfare of the child, which has taken place with this kind of therapy and which is so cheap. That's very well done.